Welcome to the Jerry Pal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who's in the studio with us today?
In studio today, we have Sarah Hooper, who is Executive Director of the UCSF UC Hastings Consortium on Law, Science, and
Health policy.
Health Policy.
We went for brevity. Thanks for having me.
So really looking forward to talk more about all three of those things. But before we do you have a song for Alex to sing?
Yes, it's a song by the boss, Bruce Springsteen. How can a poor man stand such times and live?
Well, doctor comes round here with his face all bright. Says in a little while it'll be all right. All he gives is a humbug pill, a dose of dope, and a great big bill. Tell me, how can a poor man stand such times and live?
Any reason you picked that song?
The lyrics are apropos. The patient is left with a big bill and is not totally sure what to do next. And that's sort of what we're talking about today.
So I'm going to start us off by asking a question. What is this consortium?
Yeah, so the consortium is a formal partnership between UCSF and UC Hastings College of the Law. And our mission is really to create interprofessional partnerships in education, research, and clinical training and service.
And we just had Anna Chodos on, who was talking about her work with the GWEP or GWEP of creating partnerships with a bunch of different organizations in the community, academics, nonprofits. Mm-hmm. You're part of that too, right?
We are. So we are one of the community partners in the Optimizing Aging Center. And so in our attempt to geriatricize primary care, as Anna likes to say, we are providing the legal expertise. So what are the legal needs of older adults in our community, and how can we work with healthcare providers and social service providers to enhance the capacity of all providers to provide care for this population.
And you have a particular focus on the care needs and the legal needs of persons with dementia. Is that right?
I do. So my research and teaching is in the law of aging and in dementia in particular. And at UC Hastings, we have something called the Medical Legal Partnership for Seniors, which is a clinic in which our law students and faculty provide free legal assistance to low-income older patients at UCSF Med Center and here at the San Francisco VA.
That's terrific. So can you tell us a little bit in terms of setting this up about what is the need for legal assistance in older adults with dementia?
Yeah. So the disease, of course, raises a whole host of questions about decision making. So as dementia progresses, an individual will need more and more support with decision making, with ADLs and with IADLs, and will gradually become entirely dependent on others for decision making and for providing for basic needs. And so the legal questions that raises are, what is the legal decision making infrastructure that we can create for this person and for this family? So
we're fine. We do advanced care planning. We ask everybody about their advanced directives, whether it's been done, and about life-sustaining treatments at the end of life. Shouldn't that cover? Shouldn't we be
That's
done?
An excellent question, Eric. So that is really just the tip of the iceberg. So the first part of that is we usually think of advanced care planning as being about decisions about death. And in dementia, decisions about death are an important piece of that, but what we're really trying to focus on are decisions about the moment of incapacity or that gray area where we're not sure if the person has capacity for decision making. And what do we do about that moment? And what do we do about the prospect that this individual is going to live potentially multiple years with a need for supported decision making or for someone to simply be making decisions for them? And so the medical decision making is part of that, but we also need a plan for personal care decisions, for financial and legal decision making, where the person is going to live, a whole host of things. You're essentially, think about all of the decisions that you make in your life, and now suddenly we have to come up with a plan for how someone else is eventually going to help make those decisions.
And what stage do you typically get involved? Are you talking about people who have mild cognitive impairment, who have early stage dementia, who have advanced dementia, and caregivers are coming from you to you, all of the above, or is there a primary focus?
So the medical legal partnership model is meant to be an upstream model. So the goal is really for lawyers and healthcare providers to work together to prevent acute legal needs, basically. So a lot of legal care is like emergency medical care. And so, conservatorship is an example of emergency medical care, or trying to unwind, elder financial abuse. That's something we'd prefer not to do. We would prefer to get in as early as possible to prevent those situations. So how do you do that? You do that before the individual has lost capacity. So if a patient has MCI, that's a good time to get in. Early stage dementia is a good time to get in. There are legal needs that arise in advanced dementia, and they're usually sort of caregiver focused. But again, that's not the time that we would prefer to be intervening. We would prefer to meet with a patient who's in a position who can articulate their goals of care, their goals for financial and legal decision making, their goals for their families, and we can really optimize their ability to engage in decision making and come up with a good plan and be really thoughtful about it.
And are you finding that patients with early stage dementia are typically able to continue to be involved in these decisions?
Of course.
Yeah.
So, this is preaching to the choir, but capacity, of course, is not an all or nothing proposition. And a diagnosis of dementia does not mean that somebody now lacks capacity to make decisions. Capacity is highly variable and decision specific, and that's increasingly recognized in the law. It's certainly recognized in California. And so a person, may not be able to independently manage their finances, and they might make some bad decisions, but that doesn't mean that they lack capacity to choose a financial agent, for instance, or to say where they want to live, or to hire an attorney who can help them navigate the insane patchwork of benefits that older adults have to navigate in order to access long-term care or just basic needs.
It's a really fundamental point. We may be the choir, but I think there are a lot of folks out there who have misunderstandings about the capacity of people with dementia to make these decisions. That if they're not managing their finances correctly, then they can engage in doing this sort of financial advanced care planning, legal advanced care planning that you're talking about.
It certainly raises, the potential and the prospect for undue influence. And so that's not to say we shouldn't be very careful in assisting persons with dementia with decision making, but it's not the same as saying that they don't have any legal or clinical ability to weigh in or make these decisions.
So what should the doctor's role be with all of these decisions? Because we get no training on
none
financial decisions,
Zero.
making, assessing financial capacity, wills, trusts, none of that.
Yeah. So, the first thing you can do is help screen for and identify these needs in patients and families. And I think that, Medicare and other funders or payers are increasingly interested in incentivizing this kind of whole person care planning. So there's a new Medicare CPT code that reimburses for care planning with persons with cognitive impairment. And
that doctors can use.
Or nurses. There's a whole host of health care team members that can use it.
But not social workers, I think.
Not social workers, correct, unfortunately. And not lawyers, unfortunately. But maybe lawyers should be reimbursed for this as well. But part of that CPT code reimburses for assessing not only for cognitive impairment, but for social needs of both the patient and the caregiver. And a lot of those needs are actually legal needs or have a legal dimension to them. And so So not getting reimbursed is no longer an excuse. There is a mechanism for doing this. And for the training piece of it, if you don't have a medical legal partnership in your medical center, you can partner with people in the community who can help train on this. So I would say the first thing to do is think about your patient population. Think about who in that population is at risk of cognitive impairment or decline in the next 6 months to a year, and target those people and educate them about the need for an advance directive and for financial and legal planning. And
I think that's when I think of our palliative care population, we're often working with people who may have months, maybe years, that they have to live, or that they may lose capacity at some point, even for a short period of time. Mm-hmm. And I think in geriatrics, we're coming around to the idea of medical legal practice clinics and the importance of them, at least partnering with lawyers. I don't get the same sense we're doing that in palliative care. Is that right? Is there a lot of...
Yeah, so there are almost 400 medical legal partnerships around the country now, at least one in almost every state. And the vast majority of them are focused on kids and families, which is incredibly, incredibly important. But I think that because of the demographic need and just the nature of, the complex needs that people have in geriatrics and palliative care, there should be more of us. So the medical legal partnership for seniors is one of less than a handful of these models around the country, but they are out there, and we're trying to grow.
What does it actually look like? Like, are you hanging out with the physician while they're seeing patients? Are you?
Yes.
Yeah?
Yes. So the difference between medical legal partnership and a referral into the community is that the legal team is actually integrated into the care of the patient. And so where that starts is with joint education. So for instance, in our clinic, our students are trained by geriatricians at UCSF and in the community about the health needs of older adults. We do joint training on capacity. So what's the clinical view of capacity, and then what's the legal view of capacity? How do you reconcile the two of those in an individual patient client? So it starts with training, making sure that the healthcare team and the legal team have some sort of common overlapping base of knowledge. And then with that knowledge, the providers are equipped to now start recognizing legal needs in their patients. And so now healthcare providers are in a position where they can say, hey, I think that this is really important to your healthcare, that you actually sort out how you're going to access long-term care supports and services that are going to support your goal of care to stay in your home, right? So it's one thing to say you have a goal of care. It's another thing to have the resources to make that a reality. And I think my friend down the hall is a lawyer, can provide free legal assistance to help you understand and unpack a lot of this stuff. And so the other kind of technical piece of this is there's information and data sharing that can happen through a formal. So if people are worried about HIPAA, you should be, but their medical legal partnerships have worked out a way to work within HIPAA to permit a certain amount of data sharing between the legal team and the healthcare team in order to maximize our ability to advocate together for the patient for whatever their needs might be.
That's terrific. So one thing that comes up often in dementia is the incredibly high cost, not of a healthcare, but of the needs for personal assistance, living arrangements, or supportive housing for people who develop dementia and have progressive dementia. As part of what you do, educating patients and families about what's ahead prognostically, not in terms of life expectancy as much, but in terms of like financially what they need to prepare for.
Financially, yes. And in a medical legal partnership, what's helpful is to be able to have the clinical team educate about prognosis and the progression of disease, because, we can absorb some of that by osmosis and it helps us do our jobs better, but we're not trained to do that piece. So what we are trained to do is talk about the financial and legal mechanisms. In other words, benefits, rights to pensions, those sorts of things, how to navigate the patchwork of financial and legal resources to access the benefits that you will need, how to think ahead about it. And a big piece of that is also elder financial abuse prevention, because we have a gap in coverage, as you've noted. Medicare does not pay for the majority of services that families need in dementia. And Medicaid ends up being the number one payer of long-term care supports and services. But many families overestimate the role of Medicare in paying for their costs. So they haven't planned, and they have no idea about the role of Medicaid in long-term care. A lot of people perceive Medicaid as that program for poor people, right? With stigma sort of like embedded in that, and don't realize that Medicaid ends up being the safety net for the middle class. And sometimes the safety net for higher income people who have been victims of elder financial abuse in the marketplace and have lost a lot of assets. So it plays an outsized role in care of this population. But out-of-pocket costs are also enormous. Yeah. So one thing that an attorney can do is educate about your rights within certain programs. So the Social Security program, the VA kind of host of benefits, certainly the Medicaid program, because Medicaid is essentially a series of sub-programs, and it can become very complex for people to understand how to navigate that. So a lot of legal aid offices will educate families about what those programs are, the benefits that might be available to them, and thinking ahead about, you can pay out of pocket using X number of resources for so long, and then what's the strategy going to be? And for the 10% of people who actually buy long-term care policies, they often need help navigating those policies because, unfortunately, they don't offer the range of benefits or supports that families thought they were going to receive. And so sometimes legal advocacy and education can be really helpful there as well.
So it was just a New York Times article on the ethics of, I think, asset protection to qualify for Medicaid and giving away your assets to qualify for Medicaid, even for those who are upper middle class high earners. Do you have any? Did you see that article?
Yeah.
And do you have any thoughts on kind of like what should our role be in helping people think about, for instance, asset protection with and the need for qualifying for Medicaid?
I'm really glad you asked that question. So I think part of Medi-Cal planning a good form of Medi-Cal planning is to take a whole person approach. So why do you want to be on, and I'm sorry I keep saying Medi-Cal because that's our program in California, but by Medi-Cal I mean Medicaid generally in other states as well. So why do you want to be on the Medicaid program? There are many reasons where you might not want to be on the Medicaid program, and paying out of pocket will give you more options. But if you don't understand the Medicaid program or what it means to be on the Medicaid program or what that will mean for your assets and wealth, then you will have a harder time making that decision. So I think of it first of all as just an educational tool. What is the program? Do you understand what this is? Do you understand some of the practical limitations of being on the Medicaid program? There are, even though many forms of discrimination are unlawful, for people who are on the Medicaid program, they do happen. And so part of an attorney's job is to tell you both your theoretical rights and how those play out locally, and what you might want to keep in mind in terms of access to various services. But I guess I would also sort of respond to that by asking you a question, which is, have you ever been to a tax planner?
No, but my wife is a tax attorney. Does that count?
You ringer.
Well, why do you think I asked that question?
I don't know.
So I think there are a lot of mechanisms for and this is entirely my opinion. I'm not not speaking for UCSF Medical Center or UC Hastings College of Law. This is entirely my opinion. There are a lot of mechanisms by which wealthier individuals can get information and assistance in understanding how to protect the wealth that they have accumulated over their lifetime for themselves and their families. And those are very well accepted services and mechanisms. But for some reason, when it comes to lower income people and middle class people, there's this stigma about getting information about how to protect your resources. And so, my view is that we should at least be internally consistent about our views of the rights of different people to get information and assistance in making decisions about how to manage their resources, whether that's for high-income people or for low-income people.
Yeah, we see it a lot where somebody doesn't have a lot of money. Maybe it's like $20,000 that they have left, and they make enough, to barely to qualify or not to qualify for Medicaid. But their number one goal is, more than anything, is that they want to make sure that that $20,000 goes to a certain family member upon their death. And they will do anything to protect that $20,000. And it surprised me a lot. That just happened to us a week ago on our palliative care consult service.
It happens a lot. And I think I would also, I do see it as a social justice issue. So Amy Kelly and colleagues have a really sobering paper in Annals of Internal Medicine that I really, really recommend. And they essentially looked at the cost of dementia care in the last 5 months of life. And they found that the average cost of dementia care was a little over $60,000 in the last 5 months of life. And that was entirely out of pocket. And this represented about 30% of patients' wealth in dementia as compared to other diseases. So in the non-dementia group, the out-of-pocket costs were about 11%. And it has a disproportionate impact on certain communities. So they found that in African-American patients, the out-of-pocket costs represented about 60% of their wealth. So 2/3 of their wealth went to paying for long-term care supports and services. For single women, so women who were widowed or unmarried, it represented about 58% of their wealth. And for people with less than a high school education, I think it was about 58% of their wealth. So if you think about, all of your income and assets that you've worked so hard for over your whole life, and for vulnerable populations, you literally had to scrape together, that now is going to just provide for your basic needs and your basic care. This is an untenable situation for a lot of people in our community. And I think we've set up, because of our national and state policies, we've set up an environment that is a highly complex decision-making environment. And we've essentially said, good luck to you. Go figure out how to marshal the resources to pay for this care that you need. And so I think in that environment, and we can, I think reasonable people can disagree about the best way to provide a system of long-term care supports and services. But I think we should be transparent about the fact that we have put the onus on patients and families to figure this out. And we've put this onus on them at a time when they're losing cognitive function and they're highly stressed. And it's not a good decision-making environment. So it's no wonder that almost 50% of persons with dementia experience at least one form of elder abuse. Right. These are really highly stressful situations. So, direct legal education and assistance is something we can do to help them, to help mitigate that stress and help support decision making and hopefully prevent outcomes that are really detrimental to health, like conservatorship and elder abuse.
That's terrific. We'll include a link to the Amy Kelly paper, fantastic paper, in the Jerry Pelt post that accompanies this podcast. I wanted to ask you about caregivers, because there's just a huge part of this story in dementia, and the burden on caregivers, physically, emotionally, and financially. And I want to ask how you work with caregivers in particular to support them through this process.
Mm-hmm. So an important thing that I've discovered in my work is that caregivers are just, well, this isn't news to a lot of people, but caregivers are navigating a huge number of decisions on a daily basis, in addition to grappling with the emotional and psychosocial, dimensions of caring for someone with dementia. And one piece that we can do on the legal side is, for instance, helping to educate them about their role as a decision maker for the older adult. So I have found in my work that a lot of caregivers don't really understand basic concepts like the difference between an agent and a conservator, the types of powers that they have. I hear a lot of people confusing powers under an advance directive with powers for financial decision making. We're not supporting and we're not preparing caregivers to make these decisions, and it can lead to suboptimal decision making, and in some cases, allegations of undue influence and abuse. Another piece is, ensuring that the caregiver themselves has secure housing, stable housing, that they are not being discriminated against in the workplace or in their educational place of education because of their caregiving responsibilities. So advocating on that front to help ensure that they're at least getting what they're entitled to in terms of work protection. There's a whole host of things that we can do. If caregivers themselves are economically insecure, we can assess their benefits. And obviously, if they're spouses, a lot of these things you're kind of talking about these things in tandem. But for older children, you're looking, it's a little bit of a different approach to advocacy.
So it sounds like one thing we should all be thinking about doing is setting up a medical legal practice clinic. If we're not there yet, or it's logistically impossible, can you 2 or 3 things that listeners can start doing in their practice to make sure we're addressing some of these needs?
So again, identifying your at-risk population. So
do you have specific tools that may help with that, or questions that we should ask?
Think about who is at risk of cognitive impairment in the next 6 months to a year. Think about if that individual has an advance directive. If they don't have an advance directive, they probably don't have any of their other financial or legal planning in place. If they do have an advance directive, it doesn't necessarily mean they have all their other ducks in a row, but then ask the question, have you done any financial legal planning?
And if the answer is no?
And if the answer is no, then refer them to legal aid in the community. So under the Older Americans Act provides free legal resources to individuals over the age of 60, at least in theory, in every state, in every community. So one reality about accessing legal aid is that they are incredibly overworked and underfunded, and often, unfortunately, cannot prioritize low urgency needs like advanced planning. So this is one of the needs that in MLP we're trying to bridge is, rather than wait until we're defending an eviction, can we get in earlier, right? But some communities won't have that luxury, but you can try. So start with a free legal service with the Older Americans Act provider in your community. If they are unable to take the client, then refer them to your local state bar referral service to an elder law attorney. So an estate planner doesn't necessarily have expertise in things like Medicaid for long-term care. And so referring to someone who has experience with older people or people with disabilities is an important thing to keep in mind. And I also really recommend against making direct referrals to private attorneys in the community. It's much better to go through a state bar regulated referral service so that they can do some intake and make sure that the person is directed to the right attorney.
So let's say I don't have a medical legal practice clinic or MLP, but I want to start one. Are there resources for me to do so?
there are really fabulous resources on the National Center for Medical Legal Partnership website. And then the best resources are going to be right in your community. So there are legal aid attorneys and in many places law schools that are doing this kind of work. And connecting your work is going to make a lot of sense, both for training of professionals and for better serving the clients and patients that we all work with. There are some promising things that I can mention in terms of funding. So HRSA has determined that civil legal services can be paid for using HRSA dollars, and some community health centers are doing that. Some health centers have said, we see a return on investment in these programs. So, for instance, some MLPs have demonstrated a reduction in hospital readmissions and a reduction in overall utilization cost of care. So some MLPs, one in palliative care actually in Nebraska, has demonstrated return on investment. And so the medical center is actually paying for their legal services, providing those to their patients. There's currently a proposed macro rule that would allow screening for health-harming legal needs to be considered one of the factors in MIPS scoring. So screening for health-harming needs, if the rule is passed, would be something that could positively impact your MIPS score. Other mechanisms, the VA is currently very interested in medical legal partnerships. We're still looking for a sustainability mechanism through the VA, but certainly there are opportunities to expand to VAs as well. So at the policy and kind of systems levels, there are mechanisms that are emerging that the National Center has done really great work around to enable health systems to adopt MLP.
Wonderful. Well, maybe with that, I want to really thank you for sharing your time with us today.
Thank you so much, Sarah.
And
That's
for
perfect.
the great things that you're doing out there.
Thanks.
Alex, same song or different song? What are we going to do?
Can we try that again?
Yeah.
I'm going to try it again. All right, I'm going to try to get this right this time. Well, doctor comes round here with his face all bright. Says, in a little while you'll be alright. All he gives is a humbug pill, a dose of dope, and a great big bill. Tell me, how can a poor man stand such times and live?